Yes, thank you very much. The last talk, so you are still awake. I can see some of you are not sleeping yet. But yeah, these are my disclosures, and I could also have added that I'm also a member of the IXLI group, which I'm happy about. So first I have 3 questions to you. This is the first one. How large a proportion of patients with bipolar disorder get lithium in Denmark? How many people of you believe 10%? Please raise your hands. 1, 2, 3, 4, 5, 6. 6. 30%. I waste the majority. 60%. Nobody. Okay. First question. Second question. How strong is the evidence for the maintenance effect of bipolar disorder? So compared with the evidence for anticonvulsants, antipsychotics, the evidence for the maintenance effect of lithium in bipolar disorder is equal, better, or poorer? How many believe that's equal? Please raise your hands. Come on. A few. How many believe that it's better? The majority, poorer? Nobody. And the last question, this is for clinicians mainly, or it may also be patients among you. What are your major concerns when thinking about prescribing, or let's put it that way, using lithium? The risk of kidney disease, please. Many people. The risk of myxedema? No. The risk that there will be no effect? Yeah, quite a lot. Other reasons? What is that?
Weight gain.
Weight gain. Okay. Yeah. We'll talk about some of these things. I hope that the answers will change a little afterwards, but I will not repeat it. So I think I'm going to talk about lithium use in long term. Not acutely for mania or depression, but long-term maintenance treatment. So to my point of view and to other people's point of view, there's a contradiction here, a major contradiction, that the use of lithium has decreased during the last decade, and at the same time the evidence has increased. And I will say today that the evidence for lithium is stronger than ever, and to my point of view, better than for any other drug in the maintenance phase. And this is not a Danish phenomenon, this is a worldwide phenomenon, I think it's fair to say. In Denmark, here you see the use of lithium on a nationwide basis for all individuals who get a diagnosis of bipolar disorder or a single manic episode for the first time ever, all individuals in Denmark. Who get contact to hospital psychiatry between 2000 and 2010, and we have 4 different types of drugs, and as you can see, 3 of them are increasing and only 1 is decreasing, and that is the use of lithium. And this has happened just from 2000 to 2011, not only in Denmark but around the world. And you can see here that, if we can say here we have 2018, it's about 30% of patients with bipolar disorder who get lithium at one point of time if they have a hospital contact as inpatient or outpatient. 30%. So it was not 10%, it was not 60%, but 30%. They got the drug at least once. Whether they continue, this slide does not tell anything about it. So it was the mid-answer, which was correct for Denmark. In Canada, I think it's 7% of all individuals with a bipolar disorder who get the diagnosis. In the rest of Scandinavia, it's about 25% or so. In Germany, we don't really know. In France, they estimate that it is 10 to 15% of patients with a diagnosis of bipolar disorder. So Denmark is a lithium fund nation. However, still only 30% of patients are or use lithium at least once, 1 prescription of lithium. So I'll talk more about new data and not that much about old data. This is a recent meta-analysis, the most recent we have from 2014, comparing maintenance lithium with placebo, and clearly we have an effect here being on the left side of a hazard rate of 1. This is divided in relation to depressive episodes. The same study here, meta-analysis, depressive episode. So this means preventing depressive episodes and preventing manic episodes. And again, you see it is in one type of meta-analysis clearly statistical significant in favor of lithium regarding depressive episodes. Here it is nearly, and regarding manic episodes, clearly effective to prevent manic episodes. In relation to anticonvulsants, here you see favor of lithium, nearly statistically significant. This is, I guess, a question of statistical power. The sample sizes are not that big. And then, this study was mentioned, the balance study. Just shortly, the balance study compared lithium with divalproate and also a combination group. But here is for the monotherapy lithium versus valproate. The rate of new episodes is decreased 29% among those who get lithium compared to those who get valproate. Clearly, a very strong evidence for the overall maintenance effect of lithium compared to valproate. I think it's an elegant study. It has been mentioned before. And then I'm happy that Rasmus just mentioned the Weisler study. In fact, just to add on that, this was a study initiated by AstraZeneca, who are manufacturing quetiapine. And of course, their aim was to prove that quetiapine was better than placebo, and they needed a gold standard as a comparator. And for good reasons, they chose lithium. Their aim, and I know that AstraZeneca have been selling quetiapine, stating that quetiapine may perhaps even be better than lithium, at least in the initial 2 years, during the initial stage. But as Rasmus pointed out, we have to consider the enriched design in favor of quetiapine because only patients who tolerated and responded to quetiapine in an acute phase were randomized to continue with quetiapine or change or switch to lithium or placebo. So to my point of view, this is clear evidence that, first of all, lithium is strongly better than placebo and perhaps also better than quetiapine. I think it shows, because when you take into account the enrichment design. But I will talk more about non-randomized trials or non-randomized studies, because as in fact Rasmus's study on acute mania illustrated, it's very difficult to recruit patients for trials in psychiatry, specifically if you have a placebo comparator, but also if you have another active comparator. It is estimated that only 1 in 10 of all our patients will be included into a placebo-controlled long-term trial. And for good reasons, because I guess you will not like to put your patients with bipolar disorder on placebo monotherapy. So, for good reasons. And if there is an active comparator, it increases a little to 20%. But the case is that those patients who are included in randomized controlled trials, they do not reflect real life patients, those patients that you and I treat on a daily basis. Why not? Well, the numbers says itself, but of course you know this. There are a number of reasons to why not to be included in a randomized controlled trial. comorbidity, substance abuse, and all these things, severity, including psychotic features, makes it much more difficult to include patients in randomized controlled trials. Unstable course, high risk of suicide, poor insight, denial. You never participate in a trial if you say, I do not suffer from bipolar disorder, I don't need your drugs. Of course, they don't participate. And poor adherence in all randomized controlled trials. There's a run-in phase where we monitor the level of medication consumption, and if it is negative or not in the level, of course, they're not included. So the conclusion is that what we know from randomized controlled trials is only about 10 to 20% of our patients. Real life patients we don't really know that much about. For that reason, we have to add evidence from non-randomized controlled trials, observational studies, register-based studies is a possibility, and I'll show you some of these data. This is a recent systematic review from bipolar disorder, of course, and we identified all studies, observational long-term studies, 8 out of 9 identified studies, including more than 14,000 patients, maintenance lithium monotherapy was associated with improved outcome compared with another mood stabilizer. So, and you can read the mood stabilizers there. The result shows the superiority in real life of lithium monotherapy compared with monotherapy with other maintenance mood stabilizers. Of course, there might be some confounding by indication. These are not randomized studies. I'll just present for you two of these studies, 2 or 3, I think. The first one is a Danish study from our group comparing in long-term use of lamotrigine, valproate, and lithium in bipolar disorder. All patients identified with a diagnosis in Denmark of bipolar disorder in this period here, and all with a prior diagnosis of bipolar disorder prior to one of the drugs, of course, were excluded. And this is just one result from the study. You can see here valproate being this curve here and lithium being this one, and what you see up here is the cumulative incidence of getting hospitalized after start on one of the drugs. And you can see here this is a long-term study up to about 10 years, more than 10 years. And you see here clearly that those who continue to take valproate have a higher risk of getting hospitalized compared to those taking lithium. They also stay longer on monotherapy without getting added other drugs or without switching other drugs when they take lithium compared to valproate. And completely the same figure you see in relation to lamotrigine. Lamotrigine is this curve here, and lithium is the one below. This was recently replicated in a study from Sweden. They used an elegant design because, as you can see here, they used a within individual model. So what they did was that they estimated the hazard rate of getting hospitalized at a psychiatric hospital during periods where patients were on lithium and subsequently off lithium. And perhaps if they were on again, they included that. So an on-off design, which is an elegant way to take account of confounding factors in some ways, because confounding factors are individual. So they follow the individual patient during different drug periods. So this was lithium on versus off, valproate on versus off, and so on. So comparing periods with the drug, without, and with periods without the drug. And what you see here is that the hazard rate of getting hospitalized is decreased 34% 34% when you are on lithium compared to when you are off. And all the other hazard rates, it also shows the effect of the drug, but they increase. So the largest effect is for lithium compared to when you are on the other drugs or off. You get the point here? Yeah. And that is the same pattern you see in relation to when it is regarding prevention of manic episode, prevention of depressive episodes, or mixed episode, completely the same pattern. The effect is strongest for lithium compared to all other drugs. I think it's an elegant study. Of course, again, you can say there might be some confounding issues, but they try to take that into account in the design. Yeah, I'll skip that one. Because then the question is about excellent lithium response. And Mary Lou, indeed, I think you are the world's best example of excellent lithium response in monotherapy. I'll just perhaps add that we had not such a long story for patient, but we had a patient hospitalized a few years ago in this ward. She had been taking lithium for 30 years, and her old husband then asked her, she was now 70 years, her old husband then asked her one day, these 2 vitamins you take in the evening, why do you take them? Oh, my dear loved husband, this is lithium. Have you forgotten everything about that? I'm bipolar. I'm suffering from bipolar disorder. She went up to her general practitioner. He said, my goodness, have I prescribed lithium for you for 30 years? And you have been doing well all the time, normal life, family, children, work, no problems, no side effects, 2 tablets. Please stop them. She did that right away. She developed a hypomanic episode within 14 days, and she got hospitalized in severe depressive stupor. She was lying in her bed. She was not talking, drinking, or eating. She got 3 ECTs. She recovered fully. She was a little puzzled about what had happened. We reinstalled lithium, 2 tablets every evening, and she was doing fine, has been doing fine since. So this is an it's an on-off case, similar to yours.
You can take everything away that I own, but not my lithium.
Okay. And it's cheap. So I wondered how prevalent is excellent lithium response? How prevalent do you think it is? How many people are like you?
I know about 6.
You know 6 persons? Yes. Tell me about them. No. Well, I tried to estimate the prevalence in this study. And here you see, the idea was, okay, I defined excellent lithium response in the way you do. I said, if you can stay on lithium monotherapy for many years without getting added other drugs or without switching to other drugs, and you're not hospitalized during that period, then for sure you must be an excellent lithium responder. Because if you got a depressive episode, you'll get added other drugs, or a manic episode, you'll get added other drugs or switch to other drugs. So the definition is that way. I think it's like real life. And what you see here is the rate of, here you can see patients who are not responders. And unfortunately, it comes up to that it's only about 10% or so who during 10 years are excellent lithium responders. So this is also a very strict definition I've made here, because they're not allowed to get antidepressants, quetiapine, or any drug just added once. So it's a very strong one, or a very narrow one, you can also put it. But I think these are really, really lithium responders, excellent lithium responders. Yeah. So the prevalence of excellent lithium response to lithium monotherapy is low, and as such, patients are characterized by few prior psychiatric hospitalizations, a manic index episode prior to lithium, and reduced somatic comorbidity. Nevertheless, it is the only drug I think we have in psychiatry in which patients are cured of their illness as long as they take the drug. I mean, you can have a perfectly normal life. This is, to my point of view, relatively rare with schizophrenia and antipsychotics for many, many years. They will get relapse, or they will have some social problems of some kinds. But of course, that is also debated. But I mean, lithium is really a drug for a specific illness, and some have excellent response. So that's it. Excellent lithium response, rare but beautiful. So the question is when to start lithium for maintenance therapy, and we have no clear answers in relation to that. Guidelines differ indeed. American, UK guidelines, Canadian guidelines differ. So this is, I think, in fact, the only study which has tried to investigate it. It is observational using Danish register data. So what you see here is, with the same definition, staying on lithium in monotherapy without switching, without adding any drugs, and without getting hospitalized, then the chances of having response, or here is the chances of non-response, is higher when you start following a single manic mixed episode compared to when you start later on, when you have a diagnosis of bipolar disorder according to the ICD-10 requiring 2 episodes. So these patients, they have their first ever affective mood episode. They have no prior depressions. The first ever episode, and that episode is a single manic episode or a mixed episode. And when you start following that, you have a higher chance of being excellent lithium responder. So that is the point here, suggesting that you should start early and not wait until the second time. It is debated among clinicians if a patient is hospitalized for his first or her first single manic episode, should he or her be started on lithium? For example, also if he's 17 years old in child or adolescent psychiatry, should he start lithium? To my point, yes. The chances of getting a new episode within 2 years is 60%. If you're hospitalized with a manic episode, the chances or the risk is 60%, and that is with treatment. So without treatment, I will say it is nearly 100% within 2 years. So it's a high risk, and we have to reduce it. So that was just the conclusion here. Although residual confounding cannot be entirely excluded, the results clearly suggest that early prophylactic intervention with lithium following first psychiatric hospitalization contact or a manic or mixed episode is associated with improved long-term response. We have talked about that. I will not go in details. Lithium and suicide, a meta-analysis clearly show that taking lithium compared to placebo reduces the risk of suicide. Of course, the suicide numbers are few in these studies because they are randomized, so they don't include patients who are too suicidal. So the suicidal numbers is poor. For that reason, we also have to take into account observational data. This is just a study from my group from 2005, showing that if you continue to take, or among individuals who continue to take lithium prescriptions, this is the number of prescriptions, the rate of suicide clearly decreases, in fact down to 7%, which is in fact the same as this one, nearly the same as the randomized. And then it has been mentioned, lithium and dementia. This is a similar study. Here you can see that among people who continue to take lithium, the rate of dementia is decreased substantially, not to the level of the general population, but it is decreased 15% among those who continue. Again, observational data adjusted for what we could adjust for. Then this has just been mentioned, lithium in drinking water. And if lithium in drinking water would prevent bipolar disorder, then we will get the Nobel Prize. if we could show that. And I published that last year in Bible Order. Unfortunately, it did not. So the hypothesis was that higher levels of lithium in drinking water in Denmark was associated with lower incidence, onset of Bible disorder incidence. I was so exaggerated when we did this study, because it was a major chance to get a breakthrough for
suicide dementia is.
Well, we also did it for suicide. In fact, this prior data on suicide and lithium in drinking water, they are on an ecological basis. So these are just crude data showing that the two curves cross. We did individualized data. We followed all individuals in Denmark all individuals in Denmark during different areas of Denmark. We had measures of all lithium levels, and when people move from one area to another, then we could calculate during 20 years their total intake of lithium from drinking water, because on an individual level, and we could also, for each individual, investigate the risk of developing incident bipolar disorder, suicide, or dementia. So this is the first time it's ever been done on individualized data, unfortunately negative in relation to bipolar disorder as well as suicide. So I don't believe that lithium in drinking water has an effect in relation to suicide, but in relation to dementia. Because that is what we showed here. This is just from JAMA Psychiatry last year. And this is, I had to move a little fast here, but what you see here is that if you are in the higher levels of lithium concentrations, it goes in Denmark from nearly 0 to 30, about 30, 70, 27. This is only microgram per liter, so it's 1,000 times less than in a tablet of the tablets we use for lithium. But here we showed a clearly decreased rate of dementia overall, Alzheimer's disease and vascular dementia, different outcomes, the same pattern. So to summarize this was just that the rate of incident dementia in fact increased in the middle here, but it went down and stayed a little tendency here in the higher concentrations. So that was the conclusion. I'm not completely sure that this is true finding. So for that reason, I did not contact the Danish media because I did not want the debate. They will say, please, let's put lithium in the drinking water so every Dane can get this and be happy and not develop dementia. However, I could not control the American journalists, so I was haunted down by American journalists for a month, writing and calling me all the time. So in fact, I had to take vacation for 10 days to get rid of them. It was a major thing in America. I'm still not sure that this is correct. We need, of course, some confirmatory things. The idea could be not to put lithium in drinking water, but among those of you who have a family history of Alzheimer's disease and who have an ApoE genetic polymorphism ApoE44, you are at high risk of getting Alzheimer's disease. Please take lithium in small concentrations, only 100 microgram every day, no side effects. It'll prevent your Alzheimer's disease. I don't know. That could be the perspective. Then the question of lithium and chronic kidney disease. Many of you had this as a major fright or major what's called fear for you and your patients. I'll say that based on 3 new large all register-based studies, there's no risk of developing end-stage chronic kidney disease associated with lithium. These are very firm data, very firm, and they are completely, they say the same. But of course you can develop an increased creatinine, but it does not result in end stage where you need dialysis or you need renal transplantation. And why that? Well, I think it is because we monitor lithium so good in Scandinavia and UK. These were 2 Scandinavian and 1 UK study. Every 3 to 6 months, and aiming for a serum lithium level in this area here. The story with the high chronic kidney or high end-stage chronic kidney disease is from the 80s, where the use of lithium was in an interval between 0.8 and 1.2. We know that will cause end-stage chronic kidney disease. The other thing is that suffering from bipolar disorder in itself increases the rate of developing kidney disease 2 times, regardless of treatment. 2 times. Why? Well, bipolar disorder associated with cardiovascular disease and diabetes, and both of these disorders are associated with chronic kidney disease. Yeah, I'm nearly there. I think I'll skip that one. So this is the concluding slide. Lithium, when, why, and for whom? Well, best evidence to my point of view, first choice in maintenance therapy. I'm not talking about acute treatment. My suggestion, and I think guidelines are starting to change on this, would be to start following first manic episode, at least if it is severe. Hospitalized, sure. Then we have, I've not talked about treatment-resistant depression, you know that. Of course, provide psychoeducation, secure adherence. Approximately 10% are cured by lithium, cured, so to speak, and approximately 40 to 60 patients benefits in combination with other drugs. Chronic renal failure is rare, and end-stage kidney disease is not increased. We know the other side effects. Data suggests reduced risk of suicide and dementia. And then the last point here I think is important. The decision to continue or discontinue lithium in the case of long-term adverse renal effects should not be the decision of a internal medicine, what is called in nyrespecialist, but rather the decision of a psychiatrist, perhaps in combination with this internal medicine, because the internal medicine do not know anything about the indication for lithium and do not know the patient you have prescribed lithium for. Of course, you can use other drugs if possible, but sometimes it's not possible. Thank you.